IGHS, a part of our IGHS Connect series. February is, as you remember, IGHS Connect has a theme every month, and February's theme is non-communicable disease. And it's my pleasure to welcome today for our grand rounds our speaker, Dr. Sujatha Sankaran, who's a professor of medicine. Well, I should say, so you got your medical degree at USC, correct? Right. And then you went to Georgetown University for internship. As many of you know, she now serves as director of our Global Health Sciences Master's Program since August of 2025. And she's a non-communicable disease expert, as an area of great interest for her. And the title of her talk today is The Global Non-Communicable Disease Epidemic, the Current State and Future Directions. From my perspective, and I'm sure for many of you, we do need to grow the portfolio of research and capacity strengthening around non-communicable diseases at IGHS. It's an ambition of mine to find ways to really, under the three strategic domains that we've committed our institute towards, which around education and training, research and development, and capacity strengthening, to have an impact in the NCD space is a priority. And so it's really great that you're here and part of our community now as leadership. And I think that the burdens of non-communicable disease in relation to infectious disease have often been kind of ignored. And I think it's come to much more sort of visibility and awareness in the last decade or so. So with that, we'll welcome you, Sujatha. Thanks very much. There'll be time for questions afterwards. Those online can put questions in chat. And again, welcome.
Thank you. Thanks so much for that introduction, Payam. And a really great introduction, because we're going to talk a lot about sort of the funding landscape and how we got here, and the sort of relative decrease in resources that are devoted to non-communicable diseases when you look at the global landscape. So we'll talk about sort of where we are right now, where we've been with this epidemic, and a lot of the forces that have driven the story. So I'm going to start by introducing a case study, a woman who I've known for many, many years, more than 2 decades, in rural India. We're going to talk about her story, and then we're going to broaden out and talk about the epidemiological shift that I think people know has taken place, the costs of the epidemic, both financial and otherwise. What's happening now? There's a lot happening. The WHO has had a pretty robust response. And then we're going to talk a bit about what are the frame shifts that are needed going forward to really implement change, and what UCSF is doing and can do. So to start out with, I'm going to talk about Kannamma. So this is a woman I met many years ago, maybe more than 20 years ago, in a region of rural southern India called Sitlingi. And when I first met her, she was 48. She didn't have much formal education, but she was trained to be an ASHA. So like much of as you all probably know, in much of the world, community health workers are the sort of the lifeblood of the health system. And in India, they're called ASHAs, and they're primarily women who are from villages, are community health workers who are trained from the villages to take care of their peers. So in 2005, around that time, in the early 2000s, at this site in rural Tamil Nadu in India, they noticed that there were a lot of patients who were coming in with strokes. And so it was a sort of this burden that just started to pop up. And the nonprofit, the non-governmental organization working there really presciently decided they were going to start a hypertension program. And Kannamma got trained to be an ASHA in this program. And incidentally, as she was getting this training, she recognized that she herself was also hypertensive with very high blood pressures. To tell you a little bit more very briefly about this region, and the reason I bring this up is it's such a microcosm of the NCD epidemic. And when you look at other regions of the world, this story is really replicated multifold. So this is a region that's neglected, that's designated neglected by the Indian government. Population is about 10,000 people. They, unlike a lot of parts of India, instead of being very densely populated, it's actually a very sparsely populated region where the villages are quite some distances from one another. And there's one central clinic. And again, the population is around 10,000. And like I said, in the early 2000s, they came up with these two programs, and what they called an old age program and a mental health program. And that's when Kandama was trained. And as she got older, her children, so her life trajectory was, as it is for many people, her children in that area left the villages in search of opportunity to bigger cities. And she was a force in that village, screened a lot of people. And really, I think it's the community health workers often who are instrumental for culture change in these communities. And she really brought this issue to the forefront. Around 2015, unfortunately, she, as somebody who had sort of longstanding hypertension, had a series of small strokes. And because of this, had a pretty tremendous functional decline that was a blow to her and a blow to her community. And I'll come back to her story as we sort of zoom out and talk about the epidemic, but this is a very common story globally. The numbers bear out that this is not an isolated incident. So this cartoon depicts what I think people know about the NCD epidemic. We know that as societies, as countries get, their GNP goes up, they get more resources, the rates of infectious diseases go down, and there is this transition that happens where the rates of NCDs come up. And in many regions of the world, they're sort of suffering from this dual burden of NCDs and infectious diseases as their society is kind of going through this transition. We know that a lot of this has to do with changing risk exposures, but there's a broader story around this, which I want to sort of uncover and talk about a little bit. So first of all, UN Secretary General Ban Ki-moon years ago called this a public health emergency in slow motion. And this is exactly what it's been. And you sort of see over the past 30, 40 years how a lot of these societies, as they've become more and more developed, you see this rate of NCDs increasing and untold suffering and death resulting from this. And this is a map that shows in 2023, this is the estimated share of 30-year-olds who would die before their 70th birthday from common NCDs. And the darker the red, the greater the prevalence. And you can see that, greater than 35% is the darkest red. And you can sort of see when you look at sub-Saharan Africa and Asia, just how significant this burden is, greater than 25% in many regions. So just a very, very disproportionate burden. And people used to refer to these diseases, the non-communicable diseases, as diseases of affluence. And you see that that is just not the case. These are not diseases of affluence. And they in turn lead to sort of entrenching poverty because they lead to productivity loss and economic loss. So the NCD epidemic, like Walt Whitman, contains multitudes, and it's sort of the unfortunate consequence of defining something by what it's not, right? Non-communicable diseases sort of connotes anything that is not communicable. Sort of classically, it was meant to distinguish from infectious diseases. And the four diseases that were sort of initially identified really as the core were cardiovascular disease, pulmonary diseases, diabetes, and cancers. But you can see it contains so much more. There's been sort of increasing awareness around mental health being a huge component of this. The other piece is injuries and surgeries and a lot of other disorders as well. So it's a very large bucket, which makes it really difficult to think about interventions because there's just many different ways and many different dynamics that play into all of these different disorders. I'm going to talk about some of the big ones and really zoom out about what's happened sort of globally that's caused this to happen. So there are these changing tides that have been very intentional that have really led to the burgeoning of the NCD epidemic. So specifically, tobacco use is a huge one. So tobacco use expansion into low and middle income countries has been a very concerted effort by the industry. So not an accident, something that has been a strategy by the tobacco industry. There's also been increases in ultra-processed foods that we'll talk a little bit about. And then with urbanization, you just see these decreases in green spaces, you see sedentary work patterns and physical inactivity, again, leading to a lot of these disorders. So tobacco use. So at UCSF, we have a lot of work that has been done, and we've actually been a very world-renowned center in terms of the tobacco industry documents, and so really have been instrumental in uncovering what the tobacco industry has done. If you look at these graphs, these show, so the x-axis is 0%, and you can see this is the growth, the change in market share of the tobacco industry. And above the x-axis is increased market share from 2005 to 2010. So 2005, we all know in 2005, this is not a mystery that tobacco use causes harm. But even in this period, 2005 to 10, you can sort of see that the tobacco industry has been growing in these countries. And these are the least developed countries. These are low and middle income countries that are where you see a lot of development. And you can see some examples of advertising that is targeted to some of these settings. And so this has been a strategy of the tobacco industry, and we'll talk a little bit more about that in a few minutes. Ultra processed food. So we also know that the ultra processed food market is growing, and it's projected to grow even more. And this is interesting because this is the percentage of these populations where ultra processed food is consumed several times a week or more. And you can see the top three on here are the Philippines, the US, and the UK. And if you look at this list of countries, you can see that it's a mix. There are high income countries on this list. There are low and middle income countries on this list. And so what we do know is that the consumption of ultra processed food is growing everywhere, and that the food industry, like the tobacco industry, is making a concerted effort to really expand into these low and middle income country markets. Sedentary lifestyle and urbanization. So this map is actually number of people and not percentages. And so that's why India and China seem dramatically bad, because they just have higher populations. But having said that, you sort of see that all around the world, there are deaths attributable to physical inactivity, and these numbers are really rising quite a bit. And this correlates quite nicely with the amount of green space there is. So there's just, we've always focused on the individual in terms of things like physical activity and sedentary lifestyles, but people just don't have the ability to exercise if they have no green spaces available to them. If they don't have the tools to have a better lifestyle, then their rates of having a sedentary lifestyle are higher, and the attributable deaths to physical inactivity go up. So you can sort of see what's happened here. You have these transitions that are happening. You have the climate change and the degradation of ecosystems, so traditional crops can no longer be grown. You see food insecurity, and then superimposed on that, you see the growth of these industries who have sort of filled that void, who have come in with ultra-processed foods, who have come in with sugar-sweetened beverages. The sugar industry is another one that have really expanded into these markets. And as a result, you see this nutrition transition where food insecurity is actually superimposed on the increase in NCDs and the increase of unhealthy lifestyles. And these have been instrumental factors in causing the rise of the NCD epidemic. So that's sort of thinking about primary prevention and sort of those factors. You can also think about secondary prevention and think about how we design our health systems. So our health systems, and when I say our health systems, this is a global phenomenon. It's different in different regions, but largely health systems are focused on acute and episodic care models. So people get sick, they interact with healthcare. And a lot of disease programs tend to be vertical around certain diseases. There is a limitation throughout the world in having chronic continuity care, having the infrastructure for chronic care. And this diagram is meant to sort of illustrate what an ideal system would look like, where you would have the patient, the person in the middle, the community there, community health workers supporting, having coordination between different levels of care. So having, rather than it being these sort of distinct entities, really having the continuity infrastructure where when people go to the hospital, they're informed by their community experiences, by their experiences in the clinic. And then you have public policy really bolstering some of these things up. And that has been one of the major challenges, is that our health systems have really been built upon these vertical diseases and these acute episodes of care. I think this is the sort of the most kind of dramatic evidence to what Payam was sort of mentioning around the disparity between funding for NCDs and infectious diseases. So This graph depicts from 1990 to 2025. If you look at development assistance for health by focus area, you can sort of see how NCDs is really, nothing has changed through time. So the orange, the bright orange is infectious disease funding. And you can see some other things like newborn and child health. But that small sliver of yellow at the very top, that's NCDs. And so in 2011, there was the first UN high-level meeting on non-communicable diseases. And at that time, really people in the community thought that this is going to be when things are going to change. 2011, we're going to have this high-level UN meeting. All these government heads are going to get together and there's going to be change. And it really did not materialize. That change, that increase in funding just hasn't materialized. And I think it's a quandary. I think we all talk about, like, why is this? It's not clear. I think some of the factors probably are that, donor priorities historically have focused on infectious diseases, and that's sort of continued. I think there's challenges in terms of measurement. There's also challenges in terms of politics. So having, chronic diseases take years and years to develop, and it doesn't follow the cycle of a 4-year political term, or there aren't going to be immediate results. This requires sort of long-term infrastructure building. So we'll swing back and talk about Kandama again, so I can tell you a little bit more about what happened to her. So after she suffered her strokes, she couldn't work as an ASHA anymore, unfortunately. Like I mentioned, her sons had left to a bigger city. And so her care burden primarily fell to her daughter-in-law, who did a great job of taking care of her. I think that will go away in a second. Sorry. Yeah, it's sort of, give me one quick sec here. Let me try sharing again. Oh, there we go. Okay, apologies. So her, again, she was, her sons had left, her daughter-in-law was doing a lot of the caregiving. And there were economic ramifications for her care, because now she was no longer, again, she had been this sort of force of the community, and she no longer had the ability to work. And I think just from the standpoint of how this impacted her community, I think there were just immeasurable, sort of intangible effects. This feeling that this person who had been so vibrant in their community was no longer able to work. And again, somebody who had really been a proponent of, we need to get care for chronic diseases, was no longer able to do that. So I think there's many types of costs to the epidemic. I think this graph depicts some of the financial costs. And this is a whole host of different NCDs, and you can sort of see these are projected costs up to 2030, and you can see how those rates have gone up. And there's years lived with disability as well. So there's the financial costs, there's the cost to the community, but there's also this sort of intangible disability that people have, that people are actually suffering quite a bit through these years. And so often our metrics are based on mortality and specific metrics of morbidity, but this is really these years lived with disability. There's also intergenerational economic effects, and that's something that we've seen in terms of the case I'm telling you about Kandama, but you see that all across the board, where those effects are not just limited to what happens to that individual patient, but it affects their families. So we'll talk a little bit about what's happened. So I think the World Health Organization has actually done a very good job at recognizing that these issues exist. In 2013, I think I told you in 2011, there was the first high-level meeting of NCDs. In 2013, there was a WHO Global Action Plan that was created for the prevention and control of NCDs. And this was meant to be from 2013 to 2020, sort of where we'd be and what we would start doing. Some of these things included, so the objectives included just raising the priority. I think a huge piece was just getting the word out there that prevention and control of NCDs is an emergency. It is that emergency in slow motion, that thing that we really need to deal with right now to avoid catastrophe in the future. There was objectives around strengthening national capacity, kind of understanding that each country is dealing with the epidemic in different ways. And so you really need country level and community level care that's different, but has those same priorities. To think about common modifiable risk factors. I think the thing that we all struggle with is there are so many different diseases and they have so many different causes, and how do we tackle everything? So one of the things the WHO has really prioritized is thinking about what are those common risk factors that we can make an impact on. Thinking about health systems level care, thinking about the ways in which we reorient health systems to really think about prevention, about chronic care capacity, to really, again, think about research and development and what are the ways in which we can improve quality of care. And then to be proactive in terms of monitoring, evaluation and monitoring, to have these dashboards, to really have a sense of what are the nuances of the epidemic in different areas, in different regions. The WHO at various times they've come up with different iterations of the best buys. And the best buys are really meant to be, what are those high impact things that we can do? So tobacco is an enormous driver of morbidity and mortality, and we've actually done a pretty good job globally. There's a lot more work to be done, but this is an area in which we do see some success. We know that increasing taxes on tobacco is extremely helpful. We know that graphic health warning labels on tobacco are extremely helpful. We know that banning advertising works. So these are strategies that we know work. For unhealthy diet and physical inactivity, we know that increasing polyunsaturated fatty acid intake, reducing salt intake, these things work. We know that really giving communities the ability to make the right choices in terms of food, in terms of physical activity, those things are important. We know for prevention of cancers that there are certain things that are really high impact. So we know that Hep B immunization prevents hepatocellular carcinoma, that cervical cancer screening is really important. We know that alcohol taxes work, that decreasing the ability of the industry to advertise works in terms of alcohol consumption. And finally, there's this bucket of cardiovascular disease and diabetes management, which is, again, the sort of secondary prevention, identifying people early, making sure that we have available the right medications. This has been sort of an addition that has come later in terms of the action, but really thinking about, do we have the right medications available for treating diabetes? Do we have, are these on the essential medication list? Do we have the right medicines there's often cheap medicines that can treat hypertension and can prevent cardiovascular disease. So making sure there's access for all those things. And this was extended. That was the original. Those are some of the original best buys, and this has been extended. And some of the things that have been added have been making sure that we're thinking about cardiovascular disease in a larger way, and really monitoring some of those novel risk factors, thinking about what are the technologies out there that can be used, and then continuing to tackle all of these same challenges. People might know that in September, there was another UN high-level conference. This was the 4th high-level meeting of the General Assembly. And they interestingly, and this is a really good thing, they included the promotion of mental health and well-being. So this was a conference around both the prevention and control of NCDs, but also they called out mental health in particular. And the hope at that point was that, in September, that this would be something that everybody could agree to. Unfortunately, the US did not. The US and Argentina blocked its adoption, as we often do. And even though RFK Jr. has been sort of prioritized this sort of MAHA movement and chronic disease management, interestingly, that he said that the UN draft went too far in recommending measures like taxes on unhealthy products, even though we know these things work, and while not going far enough on other things. And so they unfortunately did not want to ratify it. But it did happen in December. The entire General Assembly, it went to a vote, and the UN General Assembly did adopt this political declaration. And some of the targets are really aggressive and really promising. So from a system level, their targets are that at least 80% of countries will have policy, legislative, regulatory, and fiscal measures in place for NCD prevention and management, that primary healthcare facilities, at least 80% of them, will have the essential medicines stocked, that at least 60% of countries will think about ways in which we can limit the costs, since we know the costs are one of the big barriers. And then in terms of the targets, we're looking at what they're really aiming for are 150 million fewer people who use tobacco, 150 million more people who have blood pressure that's under control, and 150 million more people who have access to mental health care. So these very sort of ambitious goals. And as a reminder, I think people know this, but one of the sustainable development goals, the 3.4, includes NCDs. So the goal is to reduce mortality from NCDs and promote mental health. And they're looking again at these 4 buckets of NCDs: cardiovascular disease, cancer, diabetes, and respiratory disease, but they also included suicide mortality in that. So again, this is a nod to the mortality being caused by multiple things and not just these 4 things. So I think that the thing that is the most frustrating as we're sort of thinking about the epidemic is why is progress so slow? Why have we not been good at making an impact? I think you can't understate this first one, which is industry influence. The industry has had an enormous influence. And when I say the industry, that's the sugar industry, that's the tobacco industry, that's the ultra processed food industry, all have had enormous influence and they have really resisted any change. As I mentioned before, the short political horizons make a difference. And so again, it's going to take 20 years. It's hard to convince governments to put the investment now into what's needed to prevent suffering later. Primary care is so fragmented. That's another thing that we've talked about. And we just haven't historically funded prevention. I think that's another driving factor. I think it's also worth it to think about the ways in which the epidemic is different and affects different populations differently. So this graph looks at the rural to versus urban disparity in India in particular. And you can sort of see that for all of these different disorders, there's a lot of nuances in terms of the patterns of which disorders affect which populations. There are certain NCDs that are more likely to affect urban populations versus rural. The map shows unpaid domestic and care work by women in particular. So the darker red means the higher percentages. And this is for every day, what percentage of time women spend on unpaid domestic and care work. And so you can see sort of the darker orange, there's more than 25% of their time is spent on unpaid domestic and care work. And what this means in terms of the NCD epidemic is there's a lot of time that women spend on caring for elderly relatives. And that's what happens in a lot of societies. And so you can sort of think that if the populations that are most marginalized are the ones who are being affected by the NCD epidemic, then there's less ability to affect change. These are not populations that often have the political ability to affect change. And we know that the world is aging. So you can sort of see the darker red means people are getting older, and this is the 60 plus population. So this is 2012, and this is where it's projected to be in 2050. So as our population ages, as there's more migration to cities, you can see that the epidemic is going to become even more of a burden in terms of disease. So thinking about Kandama again, she's part, the story this is a powerful one, but she's part of a much larger story. And the story is about a gap in screening and diagnosis and management. It's a gap in infrastructure, but it's also a systems outcome. I think her having those strokes was an outcome of a system that was broken, and all of these larger historical forces that have really shaped her trajectory and the trajectory of other patients. So let's talk a little bit about what can be done in terms of frame shifts. I think I've said this a few times, but I think this shift from acute to longitudinal care is essential. Really thinking about determinants in terms of structural determinants rather than these individual determinants is important. Moving away from these kind of vertical systems to thinking about how do you create integrated systems. Focusing more on function and not just on mortality is important. And then moving away from an approach where it's just the health sector and really focusing on the whole of government is important. So primary healthcare is key. Having these systems where there's accessible primary care for individuals and communities is important. Not just having episodic care. That's one piece of it. really thinking about structural determinants, and NCDs are really illustrate the need for focusing on structural determinants of health, because we know that things like neighborhood and built environment make an impact on whether people can get physical activity. We know that the quality of care matters. It's not just access to care, but it's quality of care. We know that the context, the social context, makes a huge difference. With NCDs, we see that this sort of economic impacts that go beyond just the current generation. So all of these factors are really, really important. And it's important to move away from these vertical systems to think about integrating care, even though a lot of these disorders are very disparate, really thinking about common ways to, both for primary prevention and for secondary prevention. This is a map that looks at dailies in 2023. And you can see that I think it's important when we're thinking about metrics. We talk about mortality, and even with some of the goals around the Sustainable Development Goals and the WHO's goals, a lot of that is around mortality rates, mortality indicators. But reframing how we think about this and really thinking about disability is really important, because there's so much disability that NCDs cause. And people live with chronic diseases often for a very long time, but there's a lot of suffering that they're going through. In addition, I think going beyond just thinking about the health sector, some of the most impactful interventions we've had by far are actually the whole of government, the policy interventions. We know that sugary drink taxes work, but only a small portion of the globe has actually adopted these. We know that increasing green spaces works. We know that, like I mentioned earlier, having warning labels on tobacco, having tobacco taxes, all of these things work. And so really reframing how we deal with NCDs to think of the entire government is essential. There's always this question about how can technology play a role. When it comes to NCDs, I think there is sort of a ripe opportunity. Jacaranda Health, this is actually a program that is for new and expecting mothers, that uses AI prompts for self-management. But you can imagine that this is something that could be used in global settings for the NCDs as well, where you have sort of more self-management that can happen. There's also been dashboards that have been created in areas that have a lot of geographic distance between patients and providers or communities. You can use things like telemonitoring, thinking about ways in which we can task shift are important. So there's probably a role for technology as well. We know that some of these approaches work. So Thailand is one country where you can sort of see they've had a really concerted effort. They made a huge effort to really think about all of these different areas that we've talked about. And you can see that has led to a lot of success. I mean, there's still more work to be done. So one piece of what they've done in Thailand is that they have this 30-baht scheme, which is universal health coverage. And this has increased access to primary care. Also, they've had a really strong effort to increase medication availability, so these essential medications. They have chronic disease management, and they were able to cover nearly their entire population, actually, with this universal healthcare scheme. In addition to that, they've been really proactive about monitoring and registries. And so they have a national hypertension and diabetes registry. It includes things like lost to follow-up numbers. They also have a strong primary care system, and they have every citizen who's linked to a primary care unit. They've done really proactive screening of hypertension and diabetes. They have the mechanism for longitudinal management. And then on the sort of public policy level, they have aggressive prevention policies around things like tobacco taxes, the graphic warning labels they've implemented. They've really aggressively regulated alcohol, and they have a lot of food policy interventions as well. And so what you see because of all these things is that they've had a reduction in smoking prevalence. They have an increase in hypertension treatment and control. They still have a lot of work to do, but they have nearly half of their population who have been diagnosed as hypertensive or on treatment, even though they don't have great control yet. They've shown a reduction in catastrophic health spending, reduced cardiovascular disease mortality has been shown, and an actual increase in life expectancy. So it's one of those success stories that hopefully can be replicated in other settings. And it shows that you actually can control these diseases if you sort of keep that long-term goal in mind. And in terms of Kandama's story, what might have changed her trajectory? Maybe if she had had access to medications earlier, if she'd had screening earlier, if there had been capacity earlier on for risk factor identification and early management, maybe there was a role in a setting like that for some telehealth. Really care that comes from the community for populations like that, I think are really, really instrumental. So having a system that was more intact might have changed her trajectory. So what are we doing at UCSF? So I think there's a lot of people doing really great work. There's a lot of researchers who are working in this space. There's also a number of centers. The Center to End Corporate Harm is sort of a project that was created by Pam Ling, who heads up the Tobacco Center, and Laura Schmidt and Tracy Woodruff. And they've really worked to think about how do we, again, back up a little bit and think about these sort of these corporate determinants, the commercial determinants of health. How do we think about it in a broader way? Because we know that a lot of these factors are much broader than just the individual standing in front of you, and even beyond sort of traditional public health. It's really around how do these industries have an impact. We have the Center for Tobacco Control houses the industry documents, so the tobacco industry documents. And really, UCSF has been at the forefront of this work because these industry documents have been here for years, and there's been a lot of research really looking at how has the industry really, sort of knowing the harm that tobacco causes, how have they still targeted these vulnerable populations? And a lot of the work around that has come out of UCSF. And interestingly now, in addition to the tobacco industry documents, we have sugar industry documents that have been included. We have opioid industry documents, and these are all housed at UCSF as well. So we have the ability to really do this work across the board and to think about on a broader level, how do these commercial entities play a role in the NCD epidemic? We also have the Center for Health Equity in Surgery and Anesthesia, which is doing great work, the Brain Health Institute, and a lot of the work around global cancer has been quite tremendous here. So we have a lot of different pieces. I think what we don't have is sort of this overarching structure for all of the different NCD determinants. So that's hopefully coming in the future. So in conclusion, I think when thinking about NCDs, it's important to sort of look back to revisit a lot of the lessons of the past. I think the tobacco epidemic is a really powerful an analogy for what's happening now. And we're sort of seeing a lot of those same things happening again with the food industry and these other industries. And we know that again, with these long-term diseases, you really have to think about the history and all these forces that have shaped the present burden. And really thinking about the individual stories, really grounding those stories and those communities in this work, I think is really essential. I feel optimistic. I think that there's opportunity for change. I think there's opportunity for systems level change. I think there's opportunity for really grounding communities and having community informed work around NCDs, for building up health systems, for creating more equitable health systems, for sort of broadening away from just access and really thinking about quality as well with regard to NCDs. So I think I'd like to end on a hopeful note. I think there's a lot of work to be done, and hopefully a lot of this work can be done here at UCSF, and it's already being done. Thank you. I'd love to entertain any questions people have. Yeah. Rainy. Yeah, that's a great question. So GLP-1s have been added to the essential medications, and so that there was a lot of controversy over a lot of debate about whether they should be added. So they are on the essential meds list. I haven't seen them used sort of widely in many settings, and so I think there's more to come. Hopefully, I think when it comes to diabetes care in particular, I think the main sort of revolutions that we've seen have been with some of these different forms of insulin, so shorter acting insulins. Once they were added to the essential medicine list, you sort of saw that in a lot of settings that they were being adopted and there was improved control. But I think that it's a great question for the future. And I think it brings up some of these questions around best buys and cost, sort of, again, where do we put, where do we put our resources? And I don't know, we'll have to see. Yeah. Yeah, I mean, it feels as though, chronic disease is sort of, I think the technological solutions feel very sort of intuitive, right? Because I think one of the major challenges, especially when you sort of look at these fragmented health systems, are sort of how do you follow patients through these different systems? And this is an issue and I think part of why Thailand has actually been really successful has been because they have these national registries and they're really great at tracking people through the system. And it was all, and the vehicle for that was largely around their national health insurance plan. So that sort of got people into the system, and then they're able to track them through different systems. I think that, I mean, there certainly are technological solutions that could potentially help with, if you can sort of centralize some of that. I think sort of the record keeping aspect, the medical record aspect. I mean, it's a question. It's a good question, because I think there's also sort of, it has to do with resources as well. And I think sometimes it feels like we rush to these technological solutions when there are sort of solutions that don't require that expensive technology. But I think chronic diseases in particular is really, it's that longitudinal care that's missing. And so having mechanisms to really help assist with longitudinal care, I think is really key. Yeah, I mean, it's happening in a really decentralized way. And I think, I mean, that's sort of what I was alluding to with this case as well. I think that having people within the community who are really invested, who sort of see the problem themselves, are bought into it, and having them educate others around them, I think is really, really key. One thing that they've done in this community is they do have a schools program, and I've seen it in other places in West Africa where I worked. They also do these schools programs, and the idea is to sort of, as you're saying, like very early on, thinking, having people really understand healthy lifestyles early on, so those behaviors are set early, is really important as well. But yeah, I mean, I think that's important. I haven't seen it done in a widespread way, but certainly in different settings. Yeah. Yeah, and there's I mean, Alka Kanaya does work around popular, and you can sort of, I think it's both probably some genetic predisposition, but certainly that epidemiological shift. I mean, India is really at the kind of, has both ends of it. Sort of that, you still see infectious diseases, and you still see this increasing burden of NCDs as well. Yeah, it's a great question. I mean, I think that I mean, I think there's different aspects of it, right? I think the Tobacco Center in some ways is a great sort of example of how it was done really well here. And the Tobacco Center includes work around policy, also work sort of supporting research and education. So they have fellows who come in from around the world who do a lot of the research. And then there's also sort of this action component where it's not just, it's education, it's research, it's policy, but it's also they really have been really active at the forefront of thinking about political change, and so it kind of incorporates all of those different aspects. And so I think something analogous to that would be, you know, it's hard because sometimes you get sort of there's you can sort of, you know, each condition can sort of lead you to a different place. And so rather than, again, sort of stepping away from the individual conditions and really thinking about what are the commonalities, what are the common policy approaches, you know, education as a whole, how do we support education and research in a larger way, I think is important. But I'm interested to see what Payam has to say about that.
Easier to
Yeah, agree. Yeah. Yeah. I mean, I think that it's been done. I think even in low income countries, you sort of see like Rwanda as an example, where you sort of see that they've really taken a stand in terms of tobacco regulation. You know, so I mean, you see the kind of the models are sort of Thailand is a good one, Costa Rica. I mean, there are countries where they are. You sort of see in Mexico, there's the sugary. You know, they were one of the first that implemented the soda tax and taxes on sugar sweetened beverages. And so, I mean, you see it even in these poorer countries that they are sort of understanding the longer trajectory of all of the economic costs that come down the road. And so I think I mean, that's how you make the argument to these governments, right? That it's that longer cost that you're trying to prevent. And I think, and you do see, again, there are different countries in which they are adopting these things. And I mean, the US is a high income country and we're very bad at adopting these things. So I don't know that, I think that I don't know that it necessarily correlates with how high income a country is. I think there's other probably political forces as well. Yeah, I mean, I think you do a great job of stating the problem. I don't know that I don't know what the solution is, to be honest. I mean, I think it's true. I think from a donor standpoint, you sort of see it reflects the internal priorities often do reflect what the donor priorities are. And, we have not historically done a good job of thinking about what donors should prioritize. I mean, I think there are thoughts that could be changing, that in some ways with sort of the gutting of infectious disease donor funding, that when we need to rework that landscape, maybe things will change and there will be more funds devoted to NCDs. I think people in the NCD community have been talking about this for years and years. Like I said, 2011, everyone thought things were going to change, and it hasn't. So I'm skeptical, but I think I think you really fundamentally need that shift. Yeah. I mean, changes start, and I think there is work being done at the country level. That's the thing. I mean, I think that, like I mentioned, there are countries that are actually doing this quite well. So I would hate to paint a picture that we're not doing a good job, broadly. I think that there are countries who are prioritizing this, who are seeing sort of what their projections are in terms of burden of disease in the future and sort of trying to account for that. But I think that the global donor community has not sort of kept up with that. Well, I mean, I think those are all great ideas. I mean, I would sort of say that I think that yeah, you need to target it, and it kind of analogous to, when I was talking about the community, getting the community invested. I think that that goes for everywhere, right? So it's not just writing papers that only a small percentage of the population will read. It's really thinking about, yeah, how do we get our communities invested in these issues? And so that might be podcasts and all these other things. So yeah. Sanjay, do you have a question? I think so some of these policy centers, that's exactly what they're doing. So some of the work around the policy work that's happening here, that is their sort of their focus, right? To think about, like, how do we sort of research around that, but also how do we sort of promote these different policies? And so I think that's the way to do it. I mean, I think the thing that we also can do is support research in these areas. And so there are a lot of individual researchers working in these spaces. And so figuring out ways to support them, I think. Other question? Oh, yeah. It's a good question. I don't know. I don't know that we're doing that much in that area. I mean, I think there is individual work going on. But in terms of how, is there an organized effort to, and maybe you're maybe alluding to things like the fact that there aren't green spaces, there's sort of things like that. And I don't know that there's a ton directly being done in that space. I mean, I might be wrong. All right. Well, thank you all.